Welcome to Tuberculosis Unmasked, a strategic look at the scientific, economic, and social dimensions of TB. In this presentation, we'll peel back the disease's biology, explore global burden and diagnostic gaps, and outline practical strategies from prevention to advanced diagnostics, connecting data and real-world interventions to frame a coherent path forward. This slide highlights the global TB crisis. Roughly 10 million new cases and over 1 million deaths each year, concentrated in Africa and Southeast Asia. COVID-19 set back years of progress by causing missed diagnoses and higher mortality, and the takeaway is clear. Intensified surveillance, targeted funding, and equitable access are urgent to restore momentum and protect global health security. Here we unpack transmission dynamics, starting at the microscopic level, where droplet nuclei produced by coughs or speech can remain airborne for hours. Crowded, poorly ventilated spaces amplify risk. Only a minority of exposed people progress to active disease. Yet untreated smear-positive patients can infect many contacts. So environmental controls and early detection are essential to break exponential spread. This diagram walks through TB pathogenesis from initial macrophage infection to granuloma formation and latency, where roughly 90% of infections are contained, and then to reactivation when immunity wanes. The images show granulomas walling off bacteria and later liquefying to release bacilli into airways, explaining how latent infection can convert into highly transmissible active TB. Clinically, TB often starts with a persistent cough, sometimes hemoptysis, low-grade fever, night sweats, and weight loss, and chest imaging may show upper lobe infiltrates, cavitation, or miliary patterns. The slide also shows the transmission and intervention loop. Delayed diagnosis fuels spread, while rapid molecular testing and targeted screening of high-risk groups can interrupt community transmission. Extrapulmonary TB presents differently, affecting lymph nodes, pleura, bones, genitourinary tract or meninges, and accounting for a significant share of cases, especially in HIV-positive patients. It frequently mimics malignancy or autoimmune disease, so diagnosis relies on high clinical suspicion and confirmation by biopsy, molecular tests, or culture to prevent irreversible organ damage through timely treatment. This page compares molecular testing platforms that accelerate diagnosis. Expert MTB, RAREF, provides rapid automated detection and rifampicin resistance results in a couple of hours, replacing microscopy for greater precision, while line probe assays extract DNA and profile extended drug resistance. Together, they enable same-day treatment decisions, reduced loss to follow-up, and more informed regimen selection. Advanced diagnostics combine imaging, immunology, and molecular tools to improve certainty. Computer-aided detection flags subtle chest X-ray abnormalities, IGRA tests, quantify T-cell responses to ESA-T6 and CFP10 to distinguish latent infection, and integrating radiology, immunology, and molecular data yields optimized diagnostic confidence across diverse clinical contexts. Treatment is phased and adherence-focused. An intensive 2-month phase with isoniazid, rifampicin, pyrazinamide, and ethambutol is followed by a 4-month continuation phase to eradicate dormant bacilli. Directly observed therapy supports adherence and prevents resistance, while fixed-dose combinations simplify regimens, reduce pill burden, and are central to improving completion rates globally. Drug-resistant TB poses major challenges. MDR-TB resists isoniazid and rifampicin and often needs lengthy toxic therapies, while XDR-TB adds resistance to fluoroquinolones and injectables with poor cure rates. Recent drugs like bedaquiline, pretomanid, and delamanid are enabling shorter, less toxic oral regimens, but persistent cost and access barriers limit their impact in high-burden regions. Prevention hinges on vaccines and preventive therapy. BCG protects children against severe forms but offers limited adult efficacy, while new subunit vaccines show around 50% efficacy in trials. Preventive regimens, like 3 months of weekly isoniazid rifampicin, dramatically cut progression risk. And scaling targeted preventive therapy for household contacts and people with HIV is central to elimination strategies. Finally, technology-driven pilots promise to transform TB control by increasing reach and speed. AI cough screening for early detection, drones for rapid sputum transport, blockchain apps to secure adherence records, and real-time genomic surveillance to track strains. When integrated, these innovations can speed detection, optimize resource allocation, and help chart a path to end TB by 2035.